it's really challenging for them a lot of times to manage their weight, especially if they have a genetic predisposition for obesity. And genetics plays a big part of it too.
That's why people need to go to a medical professional to have that individualized treatment plan than just scroll on TikTok or Instagram and believe in some human biologist that didn't even complete like a medical degree or didn't even go through medical training or even any type of biochemistry course.
And if you see somebody who's been on 20 different programs and they have tried over and over and over, what are you going to tell them? Oh, no, this program, this time it's really going to work. This is going to be different. No, they've tried everything.
Welcome, Karli. Welcome to the show.
Thank you so much for having me. I'm excited to be here.
I am really glad that you accepted my invitation because this is the first time a PA is on the show, and it's kind of inspiring to look at your work on LinkedIn primarily, which also inspires me to just figure out what I want to do after PA school.
Yeah, I'm happy to talk about that because I think that's a big question for all of us. And I had no idea when I was going into the process of going to PA school what I would end up doing with it. I mean, I had some thoughts, but it's been kind of a winding path. And so, if people know more about this, I didn't even know the field of obesity medicine even existed when I was in PA school. So I think the more people can find out about it early on, the better.
Yeah, I honestly did not know obesity medicine existed until probably after I graduated undergrad, which is last year. I was like, I have no clue if this area existed. I'm like, I can actually wake up and do something that I like someday. Because I have my personal health journey, and I was like, I don't want to be stuck in something medical related that doesn't fulfill me. Eventually, I want to help people like how you do in figuring out how to manage weight and kind of ultimately help people for like for weight loss.
Yeah. And it is really rewarding because, as an obesity specialist, I think so many people really enjoy the lifestyle component. They're really interested in nutrition and physical activity and sleep and stress and all of those different components of, kind of lifestyle medicine. But then what we see is that for a lot of people, they're doing all those things and they're still struggling with their weight. And so obesity medicine just adds this whole other medical side to it that most people don't even realize exists. And it looks at to all these other components that could be going on and other treatment options that you can add to. It's never in place of the lifestyle stuff, right? And I think that's sometimes where there's confusion. People think, oh, you're either, using treatments like medication or surgery, or you're doing lifestyle. And it's like, no, the answer is and. And so some of these treatments, once you kind of understand them, understand why you might use them, kind of understand the pathophysiology of obesity better, then you can see how layering some of these other treatments options into the lifestyle components can really be transformative to somebody's health and well-being. And people are just so grateful when they receive that type of care. And I think for clinicians, it's really fun to do too. So I love it.
Yeah. Before diving into the components of obesity management, I want to just ask you this question. I've seen clips of the 600-pound life, if you have seen it, and how the doctor kind of interacts with patients. And I know these shows are all made for entertainment. We are not maybe that show is not focused on showing the real struggles that the patients go through when they're 600 pounds.
Yeah.
And then I think of how is modern medicine embracing what you are promoting? You're promoting sleep, nutrition, exercise. And so these components of obesity management, how is modern medicine accepting it and embracing it? That's what I always think about.
Yeah, I think, at first that was my real question too. And it was challenging. How do we do these things? And actually, that's what led me to go to PA school because I was in graduate school for clinical exercise physiology. And I remember I was talking to one of my professors and I was like, okay, so, we're inundated in this program with all of this research on how different types of exercise can help things like, people with cancer patients, prevention of cancer recurrence, people with dementia, people with depression, people with heart disease, diabetes, obesity, all of these medical conditions. We have all this data that shows that exercise can be really beneficial, can sometimes be as effective, if not more effective than medications for treating some of these conditions. So what I said to my professors is I want to create all these exercise programs for people with these various medical conditions. And that's kind of what I want to do with my career. And the professor was like, yeah, that's great. I love that idea, but there's no reimbursement for those services from insurance. They don't reimburse exercise physiologists. So you really need a clinical degree to be able to do any of that. You could go into physical therapy. You could go the medical route, like become a PA or an MD. And at that time, I didn't even know what a PA was. I was like, what's a PA? But so that's kind of how I got to that point, because I couldn't figure out how to actually get insurance, how that fits into our healthcare model, right? And
Yeah.
so what I've learned over time that now as a PA, when I do this type of counseling, so insurance reimburses for medical visits, right? So when I have a medical appointment with a patient for a variety of medical conditions, diabetes, hypertension, obesity, obstructive sleep apnea, all of these things that are affected by weight and by lifestyle factors and by obesity, I can bill a medical visit for these things. And so I integrate the lifestyle component into the treatment plan, and we can bill insurance for that. So, and I think more and more people are starting to realize that we can use these lifestyle components in our medical visits. That medical visits doesn't just mean writing a prescription or ordering a lab and interpreting a lab. Like that's part of it. But I think more and more, especially as time goes on, people are patients are realizing they want more than just a prescription. And clinicians are realizing that they need to offer more care because these chronic medical conditions, and this is what we're seeing most of our patients for, they require that comprehensive care. They require those lifestyle components to be a part of it. So I really hope, and it's one of my goals, to get a lot of this lifestyle treatment more into medical training for MDs and PAs and NPs so that we can provide that more holistic care. Because I think clinicians want it and patients want it. And we need it. Like this model that we have of this reactive medicine or this infectious disease type model where you see a patient, you write a prescription and you never see them again. Like it doesn't work for chronic diseases, right?
Mm-hmm. Exactly. I'm reading currently Peter Attia's Outlive, and it's a big book. I'm a slow reader. I'm kind of treating it as like a Bible for changing or not changing. I'm no one who will change the modern medicine, but like understanding how we are going to incorporate modern medicine and kind of bring a little bit of change from the previous medicine, the medicine of the infectious disease model.
Yeah. And I would say don't doubt yourself in your ability to change medicine, because I thought the same thing. Like, how can one person, you start with, I'm going to do this differently. And that's how I started out. And now it's kind of cool because I'm at this point where it's like, I'm not just changing how I do things. I'm able to help change, by no means by myself, but we as individuals can actually make big change in the way whole organizations and whole professions, approach things. So my goal is really to kind of transform healthcare through, obesity medicine. And what's kind of cool is we're seeing those changes now. So don't doubt your ability to make change, even as a student.
Thank you for that, because I always doubted that I wouldn't be ever able to prescribe a training program to a patient. And kind of listening to you, we're just 8 minutes in. Like I kind of have this now realization that will change and we will be able to do that.
Yeah, we actually have prescription pads through the Obesity Medicine Association. It's exercise prescription. And people will write these prescriptions of physical activity for their patients. And I think it's important that we never want to tell patients what to do. So I always want people to know that this is a two-way street. This is not like I'm writing a prescription and telling the patient, you need to do this. But we have a collaborative discussion around what are the patient's goals? What do they think they can do? What do they enjoy? what's realistic for them. And a lot of times I'm actually reducing what they initially say. So they're like, I think I can go for a walk like 5 days a week for 30 minutes. And I'm like, really? Are you sure? Like, that's a lot. Do we want to make that, how sure are you that you can achieve that? Do we want to scale it down a little bit? And so whatever that prescription ends up being, it's collaborative with the patient. But then, yeah, we can actually write an exercise prescription for the agreed upon plan that the patient can take home. And there's that accountability, right? And the next time they follow up with you, you're going to ask how that went. And if they were able to achieve that goal. And if not, that's okay, right? We adjust it. But if they were, then fantastic. Let's celebrate that and let's build on that, right?
Yeah. So how is the relationship between a medical doctor, because there is a collaborative relationship between a PA and a doctor, right? What do you like? How do you do this like in practice? Are you
Yeah.
working alongside with the physician?
So that will change throughout your career. So we all have to have that collaborative relationship with a physician, right? But what
Yeah,
that actually looks like and how much autonomy we have is very different based on the practice that you're working in and also your experience. So I think when PAs are first, fresh out of PA school, you need to have a much more collaborative relationship with that physician because you're still learning, right? And even if you feel pretty confident about what you're doing, it's good to just like bounce ideas off of somebody or double check, right? This is what I'm doing. Is this right? And so they review your charts a lot more. You can have, those conversations a lot more. But like I've been doing obesity medicine for over 10 years. And so I have a collaborating physician. And if I ever have a question or something I want to run by him or something like that, I absolutely can. But I've worked very independently for many, many years because, obesity medicine it's not really a new field. It's been around for a while. But there are few clinicians who have had as much education in obesity medicine at this point as what I have had. And so I actually teach physicians how to do a lot of this stuff. Like I speak
that's
at
crazy.
conferences and so again, it just really depends on where you are in your career, your comfort level with the field that you're working in. It also depends on your collaborating physician. Some people, are much more, they want to check everybody's charts and they feel like they want to micromanage a little bit more. And others are like, hey, I trust you, you go do your thing. And if you have any questions, I'm here for you. So it will change throughout your career. And again, it just depends on your setting and what you're doing as well.
Okay. How does a conversation look like between a patient and a provider who is trying to impose these components of obesity management? Like how does a conversation, for example, let's say we talked about exercise, but how does sleep look like?
Mm-hmm.
How, like conversation
So
about sleep.
So I think it again depends on your healthcare setting. So I work
Yeah.
in an obesity medicine clinic. So people
Mhm.
know that they're coming to me to talk about their weight and all of these different things. So what we do is we have a fairly thorough intake form, right? So when patients come and see us, they fill out this whole form and part of what we ask about is sleep. So we ask, how many hours of sleep, what's their quality of sleep? We screen for sleep apnea and things like that. So when we're doing that new patient intake, we go over that form and we kind of talk about their sleep. So that's one thing is if you already have a form that patients are filling out, you can have questions in there about sleep and kind of talk about that. Say if you're not working in obesity medicine or you don't have that type of a form and you want to bring up the topic of sleep or physical activity or weight or nutrition or any of these things, what we recommend is following the 5 A's model. And so the first A stands for ask. So it means to ask for permission to discuss something, right? So if you wanted to ask somebody about their sleep, you might be like, hey, is it okay if we talk about your sleep and kind of how that might be
Mm.
affecting your health? And then if the patient says, yeah, sure, let's talk about sleep, then you can launch into, okay, or maybe if they're like not sure, like, why do you want to know about my sleep? Like, then you can explain, well, sleep is a really important part of your overall health. And we know that when people aren't getting either sufficient, quality of sleep or quantity of sleep, it affects their hunger hormones. right? Even one night of sleep
Mm,
deprivation can increase your hunger hormones by 30% and decrease your satiety hormones and can lead to insulin resistance. And all of these things can affect your overall well being and your weight and all of that. So you can, if they're not sure, like, why are you asking me about this? Or why is sleep important? You can, have some education around sleep and then, ask them, when do you go to bed? When do you wake up? Do you wake up a lot in the middle of the night? Do you snore? Do you feel rested when you wake up? Do you fall asleep like if you're watching TV in the middle of the day, or you're falling asleep while driving? So there's certain questions,
yeah.
that you can ask. And then depending on the patient's answers, you kind of take it from there. If they're like, I sleep 8 hours every night, I have great sleep, I don't wake up, I feel rested. Okay, check the box. Like they're doing good on that. But if they do have certain issues or you're concerned about potentially sleep apnea and they need to get screened for, sleep apnea, then you kind of want to go down that route.
What role does like comorbidities play a role in obesity medicine? Because like if someone has sleep apnea or someone has like narcolepsy, how does that like have you seen in your practice? How does that impact uh obesity?
Huge. There's a huge impact of sleep. Again, if people are not getting the adequate amount of sleep, or they're not getting good quality of sleep because they have sleep apnea, for instance. And so when somebody has sleep apnea, their body doesn't really let them go into a true deep sleep because they stop breathing, right? So it kind of keeps them in this light sleep. And so even though they're in bed, they're not getting that, and they might think they're sleeping, they're not getting that deep rest. And so they wake up the next day and they're tired. And obviously, that fatigue is going to impact their level of activity. Like when you're chronically sleep deprived, you're not going to have the energy to go and be active, right? But again, it also affects those hunger hormones and satiety hormones, making people more hungry. It affects insulin sensitivity. It's a chronic stressor to the body, right? So when our cortisol levels are elevated, that affects our glucose levels and our insulin sensitivity. So there's just this, whole cascade of effects that sleep deprivation can have on a person. Or we see this very commonly too with our shift workers, somebody who
Yeah.
works night shifts. It's really challenging for them a lot of times to manage their weight, especially if they have a genetic predisposition for obesity and things like that. Genetics plays a big part of it too. And so even sometimes just helping people realize that there's all these other factors that they may not be thinking about that could be contributing to their weight. Because oftentimes people carry so much shame around their weight. They think it's something that they did to themselves. It's my fault. I know I'm not eating well, or I know I'm not exercising enough. And there's just this blame and shame game where they feel like they have done this all to themselves, and they don't realize that there might be a lot of other components, including perhaps other medications that they're taking that could be contributing to weight gain. And so we look at that too. We're really taking a good overall comprehensive look at the patient to see, what other factors could be contributing to their weight, and then seeing what we can do to help them with that. And sometimes there's things we can't change. Like you can't change somebody's genetics, right? Or maybe they're like, yeah, I work nights, but I can't change my job, But I think even just helping the patient recognize and validate that there are many other things that are contributing to their weight. This is not like their fault. And then being able to help them with the things that they can change is, I think, very empowering for the patient.
That was a lot to unpack. I mean, the first thing was like the shame, and social media really doesn't help.
Mm-hmm.
That's a whole another topic. How I was looking at this. I don't know if it was research or just like a podcast where they were saying that these young girls were comparing themselves to influencers and feeling bad. And I could like my Instagram or my YouTube could argue that I'm an influencer, but I don't look like an influencer because typical health or fitness or gym influencer looks like shredded. And
Mm-hmm.
I, in no way, shape, or form look like that because I am literally fighting genetic obesity every day
Mm-hmm.
because I have obese parents. And it takes tremendous, like, not self control, but like, it just like the environment that I am in sometimes. It's harder for me to manage weight and it is what it is. Like it's just
Yeah.
the genetics. And like I would love for you to like go into genetics a little bit here, because sometimes people feel like they have to accept that and be with that for rest of their lives.
Hmm.
What could a person do who believes that genetics is the sole factor in contributing obesity? And what's your knowledge about genetic obesity?
Yeah. So we know that genetics do play an incredibly important role in determining, who develops obesity and who doesn't. So there is a genetic predisposition that a lot of people have. So we know that there's over 200 genes, probably way more by now, that have been identified that are associated with weight gain. And the more of these genes a person has, their higher likelihood of developing obesity in a certain environment. So it's always an interaction between genetics and the environment. So the way we kind of want to think about it is, genetics loads the gun and environment pulls the trigger, right? But so both of these things kind of need to happen for somebody to develop obesity. So if you don't have the genetics to develop obesity, then even if you're in an obesogenic environment, there's a good chance you may not develop obesity. And I can use myself as an example. So I found out through genetic testing for a totally different type other thing, from a family member of mine, that I actually have genes that protect me against obesity. And so I'm a lean individual. And yes, I do the behavioral things. Yes, I do the physical activity and nutrition and sleep. And I do all those things myself. But I also know that despite the fact that I do all those things, if I didn't have the genetics that I have, I could be somebody with obesity as well. And I see my patients who have obesity who do all of those lifestyle things too, and yet they still struggle with their weight because they just have a different genetic makeup. And so again, but it's an interaction between genetics and the environment. So if somebody has the genetics, has strong genetics to develop obesity, that doesn't mean that it's hopeless, that they're just going to have obesity no matter what. But it does mean that, like yourself, they're probably going to have to work harder at it
Hmm.
than somebody who doesn't have those genetics to manage their body weight, and especially in this environment that we live in. And most people do have multiple genes that predispose to weight gain because these genes helped us survive for millions of years, right? If somebody was good at storing fat, that helped us survive periods of famine. We have to remember, humans, we were hunter gatherers for most of human history, right? So those genes helped us survive. And so the genes haven't really changed, but now we live in this environment that's not a hunter gatherer environment. And the foods that we're eating are very different. Our lifestyles are very different. But we still have the same genes. So a lot of people that have that genetic predisposition are more likely to gain weight. It's kind of like I explained to you, some people, they can read a book and basically memorize it. They don't have to study much for tests. It's just like things come to them easily. And there's a genetic component to that too, right? And other people, they just have to work harder at it. They have to study harder. It doesn't mean that they can't still ace that test,
Yeah.
right? But there's a different effort that has to go into it. Does that kind of help
Oh,
explain the
definitely.
genetics model a little bit?
I love this conversation. Like this conversation every time like lights up my brain. It's just so it's my best thing to talk about. Uh and again to point that evolution part, I read in Outlive that when humans moved from Africa to Europe, the climate changed. The climate was colder, and in colder months, we had the ability to store more body fat. And
Mm-hmm.
so now when we look out in the world, we have these different races, and some people or some races can store body fat, but they're metabolically healthy despite being obese, while others look skinny, but they can have metabolic syndrome.
Right,
And
right,
that the evolution explains that. And again, the nutrition and the hyper accessibility of hyper palatable food also doesn't help.
right.
And
Absolutely.
yeah, so
And so,
what?
yeah, a lot of that has to do with, and so I talk to people about, our fat storage capacity. Like
Hmm.
some people can store large amounts of body fat because they have a lot of subcutaneous stores of body fat. And so they might have, per BMI, obesity, but you look at their labs and they're metabolically, they're perfect. There's no metabolic complications there at all because they have the ability to store a lot of subcutaneous body fat. And subcutaneous body fat is not metabolically unhealthy. There's nothing wrong with it. What I will say is some people like that, though, they may not have metabolic complications of obesity, but they might have biomechanical problems. So they might develop, joint pain associated with the excess weight, obstructive sleep apnea, GERD, other complications. So I don't want to give the impression that just because somebody doesn't have metabolic complications of obesity, that it doesn't necessarily affect their health, because it could be affecting them in other ways. But if somebody says, like, I feel great, I have no joint pain, their labs are great, their vitals are good, their blood pressure is good, but they carry body fat in their subcutaneous adipose tissue, but they feel great and they can do everything and metabolically they're healthy. I'm like, great, like that's not a problem. And so I think part of the problem is how we define obesity. And we have a really poor definition of what is obesity and who might need to be treated and who doesn't need to be treated. We have this BMI cutoff, which really doesn't tell us much of anything. Or it's just a ratio of your height to your weight. It doesn't even tell us about body composition, much less where that body fat's being stored. Whereas, conversely, like you said, you might have people who can't store very much subcutaneous adipose tissue. So they look lean on the outside because they don't have a lot of body fat. But because they can't store it in their subcutaneous tissue, they start storing it in their organs, in their liver, and their pancreas. And so that's when you get those people who, even at a fairly normal BMI, have a lot of metabolic complications. And so, so when you look across the world, there are some populations, like maybe people, from Southeast Asia and from an Asian background. But again, that's also a generalization because you can have people there too, so it really comes down to kind of assessing the individual, person rather than looking at, broad numbers and generalizations.
That's why people need to go to a medical professional.
Yes.
To have that individualized treatment plan than just scroll on TikTok or Instagram and believe in some human biologist that didn't even complete like a medical degree or didn't even go through medical training or even any type of biochemistry course. Because there are so many of them right now who can like say this one thing, A equal to B and B equals to C, and that's how it should work, and that's how it works with everyone.
Yeah.
And when I talk to you and when I talk to other people, it's not the case.
No, not at all. And also how different people respond to different therapies, whether they're lifestyle therapies or medications, so different. So just because something worked for one person doesn't mean it's going to work for another person, or, so that's why that individualized approach is so important. And that's why I spend so much of my time teaching other clinicians how to kind of take this individualized approach and how to do this, because right now it's not really something that's taught in medical training, especially around obesity care. There's still very little obesity training in most medical, PA, NP schools. So
what is your thoughts on our knowledge about nutrition and how do you tackle that in clinical setting?
Yeah. So again, through the Obesity Medicine Association and other organizations, I've done a lot of training in nutrition, also a lot of like self-studying and books. You mentioned Peter Attia. He's great. I also love Ben Bickman, who has a book called Why We Get Sick and What to Do About It. And it's all about insulin resistance. So, through my own education and reading, again, when it comes to books, there's a lot out there too. So make sure, the sources are credible and reliable scientists and, people who are really specialists in this. But so over the years, I have had a lot of nutrition training. So, again, it also comes down to an individualized approach. I do think that a lot of the medical problems that we see today are driven by insulin resistance. And so that is something that I talk to patients about a lot. And I don't think that there is one dietary plan that works for everybody. Again, because we're also different, also in how we process nutrients and how we absorb nutrients and how those affect us. So there is no one size fits all, but I try to get everybody more towards a whole food plan, like away from processed foods, because we know that those foods are a problem, right? There's kind of an underlying similarity between a lot of these different nutrition plans, whether it's Mediterranean or low carb or Whole30 or whatever, but kind of as underlying current is that we should try to move away from processed foods towards more whole foods if possible. And then probably, we know that Americans are consuming 300 to 400 grams of carbohydrates per day. When you look at how nutrition has changed from, say, the 1960s and 70s to now, we know that people are consuming about 400 calories more, and most of those calories are coming from processed grains and processed sugar and added fats in processed foods. So if we can try to start, working some of those foods out. The only exception I'll make to that is meal replacements. So we do use meal replacements with some patients, especially as they're transitioning to eating a more whole food diet. Some people do need a little bit more structure and need to get away from all the decision making and need to get away from some of the other processed foods that they're eating. So that's kind of my exception when it comes to whole foods, is sometimes we do use some of those.
Awesome. This conversation is like kind of, I'm answering my own questions that I had through this about PA school and obesity medicine and being eventually like a maybe preventive, like working in preventive medicine setting. So this is awesome. What's the role of calories and how do you communicate like the importance of calories and staying under your caloric budget to your
Right.
patients?
Yeah, a couple things. I mean, first thing we do is we kind of assess. So we do a body composition analysis, and in some of the clinics I've worked at, we've done resting metabolic rate. So you kind of really have a better idea of where somebody's kind of basal metabolic rate is.
Yeah.
So that's a good place to start. But the difficult thing so we know that in order to lose weight, we do have to have a certain calorie restriction, right? You have to be consuming fewer calories than you're burning, right? In order to be in a calorie deficit. And we can argue with how much insulin plays a role in this versus calorie deficit. I think it's both. I think this idea of it's calories versus insulin is kind of crazy. I think, it all matters. It's this and this, not this or this, right? But I think the trouble with calories is, in order for somebody to stay at a calorie deficit, that makes people hungry, right?
Yeah.
Like if you've ever tried, anybody who's ever tried
I'm
to lose
currently on
weight,
a deficit.
right? Like, and then when you lose weight, there's these biologic adaptations that occur that your body actually increases your hunger hormones, decreases your satiety hormones, and slows down your metabolism, because your body, again, is trying to get you to regain that weight. Because historically, when we look at how we've adapted over time, our bodies tries to defend us against weight loss. So again, if we lost weight in our hunter-gatherer days, it was because there was a famine, there was no food around, maybe we were sick and we couldn't get up and find food. So when we lose weight, your brain still sees that as a threat to your existence. So it tries to get you to regain that weight. So maintaining a calorie deficit for a long period of time is very, very challenging. So a couple things that I do. First, when I first talk to people about their nutrition plan, I don't even really talk about calories. I talk about two things. I want to try to lower their carbohydrates, usually 100 grams per day or sometimes less. But we kind of start out there. And then I want to make sure that they're getting sufficient protein. Because a lot of times when people try to go on a calorie deficit, they eat less of everything, including protein. And so when people aren't getting enough, protein is also the most satiating nutrient, right? So it keeps people full longer. We also burn more calories just processing protein than we do any other foods. And we need it. It's necessary for our muscles, for our cells, these amino acids are the building blocks of everything. And so when people are losing weight, a lot of times they lose muscle mass along with that. A
Mm-hmm.
significant amount of the weight that's lost is muscle mass loss. Now, some lean mass loss, some muscle mass loss may be normal, but if you're losing more than 20% of the weight that you're losing is muscle mass loss, that's not okay, right?
Yeah.
So I tell people, we work on minimizing the carbohydrates, especially from processed foods. We talk about making sure they're getting sufficient protein. So depending on the individual, that might be, 70 to 90 calories for maybe a woman or a short woman, maybe for a man, depending on their height and their activity level, might be closer to 100 or 30 grams per day. So whatever that kind of is. So if they're doing those two things, they're watching their carbohydrates and they're getting enough protein, then we can kind of see where their calories fall and how their weight reduction is going. If they're doing those two things and they're still not, losing weight or their body composition isn't going in the right direction, then we can, talk about calories and other things. But I think hunger is really important to talk about, and the composition of what those calories are, consist of. And then if people are really struggling, if they're they're adjusting their nutrients, but they're not able to get into the calorie deficit because they're hungry, which is a normal physiologic thing to feel. And I think it's very difficult if somebody's hungry all the time. You can't expect somebody to be hungry and to be successful with sticking to their nutrition plan, right? It's just impossible to ask. So that's when we talk about, maybe including some of those other options, like adding pharmacotherapy or even, surgery or something like that to address the hunger issue or the appetite issue.
Awesome. I can't wait for a day where I could just tell a patient you need to eat like 1.2 grams of protein per kilogram of your body weight. Like that has been like one of my goals. If I could get to that place, I'll feel fulfilled. Because
Well,
I
come
know
to
how.
OMA and you will hear whole, lectures about that. And that is what we tell people. And that's what obesity specialists talk to patients about. And that's what we do. And then we have all the evidence behind it, right?
Yeah. Yeah. I mean, I looked at all those studies that you mentioned, like how lean body mass is affected when you are in deficit, even if you're intermittent fasting. I read this one thing about how if a group of people don't measure their protein or exercise, like weight training, while
Mm-hmm.
they're doing 8-hour intermittent fasting, they will lose significant amount of lean body mass compared to people who have high protein and who are doing some sort of physical activity, preferably weight training.
Yeah.
So
So
all
that's
of
the
this
other
just
thing.
comes together.
Resistance training, we talk about that so much. And especially with some of these newer medications that we now have that really significantly suppress appetite. My
Mm,
concern is that, yeah, people are going to lose weight, but unless the clinicians that are prescribing these medications are talking to people about their protein consumption and about
yeah.
doing resistance training, if those conversations aren't being had and people are just being prescribed these medications, and yeah, they're losing a ton of weight, but nobody's monitoring their body composition or knows what they're consuming, we're going to have a lot of like lean mass loss, muscle mass loss, especially when you're thinking about, in people, older people, right, that already have a reduced muscle mass. This could really end up in like, frailty, sarcopenia, like all these other issues could happen. And even in younger people, this is when we build our muscle mass up, right? Is during our younger ages. So if they are losing muscle mass during their younger ages, well, what is that going to look like when they get to middle age or when they
Yep.
get older? Right. So just like we've done a good job with osteoporosis and talking about like making sure that people are doing weight bearing exercise and getting calcium and, doing those things during their bone building years, which is really teens and 20s and stuff. We need to be thinking the same way about muscle. Muscle is so incredibly important for overall health. And unless you have clinicians who are trained to talk about these things and know what to say to patients and understand what all that looks like, um, we need to have that type of training around these medications as well so that they can be used safely and appropriately in the right patients.
So how far are we? I haven't been like really into the into drugs right now for obesity medicines. Well, how far are we in terms of like prescribing I don't even recall drugs right now, but how
Mhm.
far are we into prescribing them right now and putting them into effect?
Yeah, so I think just in the last year and a half, we've seen a really big change with the development of some of the newer drugs. So, in the last 2 years, there were two new medications that were approved for obesity treatment.
Mhm.
There's, Wegovy or semaglutide, which is this same drug as Ozempic at a slightly different dose, and for the treatment of obesity, whereas, Ozempic is for the treatment of diabetes. So a lot of times people have heard about these medications on TikTok and like social media and stuff, but that's where they're getting their information from. But so, these medications are approved for obesity treatment. And then there's just a new one, tirzepatide, which was previously approved for diabetes under the trade name Mounjaro. And it was just recently, a few weeks ago, approved for obesity under the name Zepbound. And so what we're seeing, especially with some of these newer medications, is we're achieving an average weight reduction of 15 to 22% total body weight loss, which when you look at things like bariatric surgery, the sleeve gastrectomy is around 20-25% body weight loss. Room-wide gastric bypass is around 30%, 35%. And previously, the medications that we had, we're getting maybe 5 to 10% total body weight loss. So now we're seeing almost twice as much weight reduction on average with some of these medications because they do a really good job of helping people manage appetite. So they work in that part of the brain that manages appetite regulation. And so it allows people to eat fewer calories without feeling hungry all the time, right? And that food noise that people often get when they're trying to manage their weight, they're trying to lose weight. And now, next thing you know, all they can think about is food, right? Because that's our body's response to weight loss and to, reducing our calorie intake. So I think that it can be very helpful for people who've struggled with obesity and haven't been able to lose weight. A lot of people think that lifestyle changes are the golden ticket to weight loss. And for some people, they can be, right? Some people can have significant weight reduction with lifestyle changes alone. But when you look at as a whole, it's only about 10% of people or so who can lose a significant amount of weight and keep it off long term with lifestyle changes alone. Most people, what we see is they lose weight for the first, 3 to 6 months, then they kind of plateau. And then over the next 6 months or so, they slowly, gradually regain the weight and they blame themselves. They're like, well, I must be falling off the wagon. I must not be trying hard enough there. I must be doing something different. When in fact, it's just their body fighting that weight loss, trying to get them back to their previous weight set point. So that's where these medications can be very helpful so that people can not just lose the weight, but actually keep it off long term. So they can be very helpful. What's the uptake of this? Well, up about 2 years ago, it was only 1 to 2% of patients with obesity who are actually being prescribed these medications, and only 1% of patients kind of undergoing metabolic and bariatric surgery of those people who qualified for that. Now the uptake's a little bit more. I think we're close to about 4% of patients are being treated with anti-obesity medications. It's still a very small percentage if you compare that to, say, diabetes, where like 86% of patients with diabetes are being treated with pharmacotherapy. And again, I went into this field because I really wanted to focus on lifestyle and I was kind of anti pharmacotherapy. But once I understood why it's so challenging for a lot of people with obesity to lose the weight and keep it off, and that it really has a lot to do with these biological changes that happen, and you see the impact that some of these medications can have on people, it can really be life-changing and transformative for patients.
Yeah, it's funny how you say you were against pharmacotherapy because I think 1 year ago when I was just applying to PA schools the first time, I was like, do I even want to do this? Like, do I want to
Mhm.
even put myself through? Because like, why am I biased towards not believing in pharmacotherapy? But when I learn more credible stuff, like when I invest my time into like research papers or listening to legit people, not some
Mhm.
social media influencer who doesn't know what they're talking about, but when I talk to people like yourself too, it just like kind of gives me hope that like medicine is not dead. Like we can really impact medicine and use pharmacotherapy in our benefit.
Yeah. Yeah. And again, it's not either or, right? It's really how can you find the right fit for the right patient? It doesn't mean everybody needs to be on pharmacotherapy. Again, it comes down to like the person in front of you and what have they tried, what works for them, what doesn't work for them. And if you see somebody who's been on 20 different programs and they have tried over and over and over, what are you going to tell them? Oh no, this program, this time it's really going to work. This is going
Yeah.
to be different. No, they've tried everything, right? Like, and then if you have a tool that can help them, and yes, you're still talking about all the lifestyle changes too, right? It doesn't get rid of that. You're just giving them an additional tool in their toolbox. And it can be, like I said, just really life changing for people. And I think sometimes there's shame around even using medications or surgery, and people thinking, well, this is the easy way out, and I should be able to do this on my own. And I would just like to tell people to, it's not the easy way out. It's just a tool. And yeah, I hope that we can get over that stigma associated with medications as well. It's just like, in mental health, I mean, I think it's gotten more acceptable that yes, depression is a disease state and some people really benefit from pharmacotherapy. That doesn't mean that like going to therapy and doing mindfulness things and exercising and eating well, like all of those things help mental health as well, right? But for those people who need a medication for them to feel better and for them to feel okay, like that's okay, right? So I hope that we can get to that point with obesity as well, where we say, yeah, some people it's not a crutch, it's just an extra tool to help you feel your best and be the healthiest, happiest version of yourself that you can be.
10 years from today, how do you see obesity medicine in terms of pharmacotherapy and even the other aspects of obesity management like nutrition, sleep, and exercise?
I honestly, I can't even comprehend what it might be like 10 years from now, because 10 years ago, when I first, kind of got into this field, I was working in bariatric surgery. I remember one of the first conferences, and this was before a lot of the anti-obesity medications. So some of them came out in like 2012, 2014. So this was before even some of those medications came out. We really had very few, if any, options for medical treatment of obesity. And I remember learning about all these gut hormones that affect appetite that are affected by bariatric surgery. So we're learning about CCK, GLP-1, OXM, PYY, like all these hormones and ghrelin, all these hormones that change with bariatric surgery. And I remember thinking like, well, gosh, now that we know about all these hormones, why don't they just make medications that like affect these hormones? Like, why hasn't somebody come up with that? Right.
Yeah.
And that's where we are now. Like, even just like a year after that, oh, this new medication came out. Oh, and this medication affects this GLP-1 hormone. So to look like now where we are with all of these, especially in the last couple of years, with these new medications that have come out, and now like there's so much stuff in the pipeline in terms of anti-obesity pharmacotherapy development, because we just understand the pathophysiology, we understand the biology so much better. So honestly, like I can't even imagine where we'll be in 10 years from now. And my hope is that, we find safe treatments that are affordable, treatments that everybody have access to, because right now that's still a real issue. Insurance coverage. And
Yeah.
then even if you do have insurance coverage, now there's all these shortages of these medications. So like, access to care and cost is a real issue right now. So I'm hopeful that 10 years from now, we'll be like, remember those days when like nobody had coverage and, so I'm hoping that that will be behind us and that it will just be a standard of care and that we can really start addressing all of these things much earlier so that we can really, reduce the burden of all of these chronic diseases, right? If you think
Yeah.
about what an impact all of that would have on people, even like cancer rates, diabetes rates, cardiovascular disease. I mean, joint replacements, all of these things that we're seeing, if we can get ahead of all of that, focus more on lifestyle, focus on the preventative side too. And then if people are starting to struggle, helping them get back on track earlier before they develop all these complications. Because the way it is right now is like we're taught to treat all the complications of obesity and all of that. And then half of the time, the obesity is not even diagnosed. And if it is diagnosed, only, about 24% of those people that have a diagnosis of obesity ever have a follow-up appointment to address it. So they might be being treated for all their complications of obesity, and nobody's ever even talked to them about their weight or ways that they could potentially help them with that or refer them to somebody who can help them with that. Right. So my hope is that we reverse that, that we really focus on prevention, and that, we address all these things earlier before people develop all these complications.
Well, thank you for serving the medical community and promoting the obesity management care program, because I think we need this. And you've definitely inspired me to go to this route. And I'm sure you have inspired many others through your podcasts and through your content creation. So
well,
thank you for joining this
Thank you
podcast.
so much for having me on, and for the opportunity to talk about this, because I think it's one of those things that there's still so much, lack of understanding around and so much mystery around. And so whatever we can do, thank you for your efforts to spread the word as well.
Thank you so much. And I'll put all the links down below in the description, and all the resources that you have also will be in the description. Perfect. Any last message to our audience?
No, it's just, if you're a medical provider, check out how you can learn more about obesity medicine. And if you're somebody who's struggling with their weight, or somebody who's struggling with their weight, know that there are medical providers with real evidence-based, compassionate treatment options out there for you, that you don't have to do it on your own. And that, again, that there's help.
Awesome. Well, thank you everyone for tuning in to today's episode. This was great. This was inspiring, very aligned to the mission of my podcast. So thank you, Karli, for joining. I'll definitely keep in touch.
Thank you so much.
Thank you. Thank you for watching this entire episode. If you did, I cannot thank you enough for your support and exploring my personal interest in obesity management and obesity medicine as an aspiring PA. Today's guest was Karli Burridge. Karli is a board-certified obesity medicine physician assistant, founder of Gaining Health, and the host of the Gaining Health podcast. Her experience in obesity management, bariatric surgery, psychology, exercise science makes her a nationally recognized obesity expert. Currently, her company Gaining Health offers tools and resources for clinicians and organizations to incorporate obesity management program. Please follow her tremendous work to revolutionize healthcare with obesity medicine. Karli makes regular content on LinkedIn, which is really educational, but also inspiring for students just like me. And so I hope you check that out. And thank you for watching this important episode. I'll catch you in another episode or a YouTube video. Take care and happy holidays.